Oh, there we go.
Awesome. Hey, thank you for waiting.
No worries. Yeah, hey.
Awesome. Hey, good to see everyone. Good to see you.
Good to see you.
Yeah.
You too.
Here, give me a sec to get everything set up. Okay, perfect. Now I am going to start the official recording, share my screen. Okay, can you see my screen?
Yes.
Okay, awesome. All right, let's get started. So, Madison, so you said, I inherited a 16-year-old female, so she has ADHD and depression. So she was diagnosed with bipolar, but you're not seeing that. Has borderline traits, refuses to do therapy. Okay. So she's on Prozac 20, Abilify 10, and Adderall 20 in the morning, and Adderall IR 10 twice a day in the early afternoon, around 6 p.m. Is this safe dosing for her range, for her age? BP and HR are stable. Tried Vyvanse, we're off around 12. Reviewed her genetic testing, states she's a normal metabolizer. And then, so just a question, this is a patient that you're managing, like, or?
Yes, they came to see me to establish care, because their primary wanted her to see someone in psych. But the primary care provider was managing all of this, yes.
Got it. So this is the primary's regimen, not your regimen.
Yep.
Got
so
it.
She came to me on all this, yeah.
Okay. And so she says she has fatigue, relying on the Adderall for energy. If she doesn't take it, she sleeps all day. Got you. Depression stable, Abilify. Okay. So it sounds like your questions are the safe dosing.
Yeah, like, is that that's basically my main concern, is just the safety of it. I found kind of like conflicting things about that dosing, but also the fact of, I think she seems to be using it not more so for her ADHD, but more so because there's some underlying reason for this fatigue. But I just don't know. I saw her and she said, she's doing really, really well. So then I'm nervous to make any changes. But at the same time, I'm just worried about the dosing, if it's appropriate with like that. I don't know. That setup. So.
Gotcha. Yeah, that's totally understandable. So let's work through everything one by one that you said. So the first thing that you said was the dosing. So what we have to remember with adolescents is that and kids is that paradoxically, they may actually need higher doses than adults because their metabolism tends to be quicker than adults. Just on average, they tend to metabolize stuff. And this was a surprising fact for me too. I remember I learned this in my child and adolescent fellowship, and I was like, because I thought the opposite. And so it's actually not the case. Sometimes the dose might decrease as you come to an adult, and you might find that adults need less. So in this case, we know the FDA max is 60 milligrams, but that's a guideline. And so here she's on 20 in the morning and then 10 BID IR. So I don't think that the dosing here is a problem. So like I wouldn't personally have any problem with this dosage. But your second thing that you're saying is the fatigue, relying on the Adderall for energy. So walk me through, what are your thoughts? What's your conceptualization of this patient? What's your next steps you're thinking?
Yeah. Well, she had made the comment of, the only reason I'm upright is the Adderall. Like, she is, she's like, if I don't take it, like with the Vyvanse, and she was on, 40 milligrams. She wasn't on a super high dose of the Vyvanse, but she's just like, it wears off. I take it before school, it wears off at noon, and then I'm taking naps all day long. And then, I mean, she said since it switched to this structure, that she's doing really, really well. So then again, I'm like hesitant to rock the boat, but she did get a bunch of labs done. I haven't heard yet, so I'm curious to see what that comes back as. Because I think they did a full panel of like her iron and vitamin deficiencies, all of that stuff.
Yeah.
Because I just feel like it's normal. I mean, she's healthy, she's active. I mean, I just don't feel like it's normal for her to have this much fatigue.
Mm-hmm.
But that's my concern, is just, again, she's difficult because she's interesting. So I'm worried about future too, like dependence, just for the way that she uses it. But again, I guess I don't really know what to do. And maybe I'm thinking into it too much, other than the fact, I mean, she's doing really well right now. So
yeah. So let's definitely we'll talk about that too. What I want to ask you about is, what is your current gut telling you to do here?
Well, because I definitely would want to. I see her again here on Thursday, and I want to talk to her just about like how she's using it and what it's meant for, and that it's not, for the fatigue.
Right.
It's to help her focus, and because she's in summer school, she is in like sports, she works, so that is what we're treating with this. I mean, I was going to kind of maybe even talk to her too about like, if you don't need the third dose from that you take at 5 or 6, like just don't take it on certain days that you don't have anything. That's kind of what I was going to start at, instead of coming at it from, okay, I'm just going to take this away from you, or like take you off the dose.
Yeah.
But again, as long as like the dose, my concern was the dosing initially, or like just safety, but then also how she is using it. So that was kind of what I was thinking to do first when I see her again this week.
Mm-hmm. Yeah, so I think you're definitely on the right track. So it sounds like you want to explore with her what this fatigue is. Think about lowering the third dose. I do agree with you. There is probably some elements of dependence, especially if she says she can't do anything without it. I remember I had this patient who was on these super high doses of stimulants, and in fact, his wife called me unbeknownst to the patient, saying that this guy is dependent, and pretty much if he doesn't get his high dose of stimulants, he will stay in bed all day, he'll lash out at everybody, he will be completely irritable, and he just absolutely needed it to function. So it was pretty obvious that they were causing more harm than good. So in her case, if there's major fatigue, my question is that this seems to be more than just ADHD now that we're managing. So one, what is this fatigue being caused by? Is it heavy menstrual periods, right? She's a teenager, irregular hormones, nutritional stuff. Is there any kind of substance use that she's doing? So it sounds like she's being worked on that. In terms of things that you could do, modafinil is a good intervention, especially if you're trying to target fatigue, because it lasts a lot longer. The problem with something like this Adderall regimen is that it'll go up and then down, and then you're recompensating with the IR, then going down, then recompensating. And whereas with the modafinil, it's a lot more longer lasting for fatigue. So I remember I had this teenager, 17, 18-year-old male, who had fatigue, especially in the morning, getting up, getting his day started. And when we started modafinil, around 200 to 300 milligrams, that's what made the difference for him. And he was able to get up and get going throughout the whole day because it lasted a while. So that could be an option if there's comorbid depression. Maybe something like Wellbutrin could be assessed too, because then you'll get more of that energy throughout the day spread out, rather than this like up and down kind of problem or pattern that we're having.
So are you saying like switching to the modafinil, or adding that on with that?
Switching. So if you're just targeting fatigue, you could switch to the modafinil. If you feel like there's severe ADHD along with fatigue, then maybe a longer lasting one like Vyvanse or Concerta, just for more stability. Because with the Adderall ER, so you're getting about 8 hours, 6 to 8 hours, and then you're IRing, and then you're IRing. So you're literally doing this up and down kind of pattern.
Mm-hmm. Well, and that's, part, because she did try Vyvanse, but then was
Yeah.
saying it doesn't last long enough. It wears off super fast. But yes, the up and down, that makes sense.
Yeah, I would also check for addiction as well, to either to this or to any other substance. For example, if she's using cannabis or something, that would be a huge factor.
Okay. But I wonder if she would admit to that with me. But
Yeah.
I could have her take a test too. But that's a good point.
I mean, yeah, there's pros and cons to that, because your ultimate goal is that you want to establish a good relationship with her so you can take care of her long term. And so if you spring a UDS on her the first or second time you see her, you might lose some of that trust. So in my opinion, it's a better approach to build that trust, so that way she feels that she can disclose to you honestly whatever she's doing.
So as far as, for right now, like safety wise, she is good.
Okay.
So that saying, it's just not, is that correct? Like, it's okay to keep her on that for now?
For safety wise, I wouldn't be worried about like a 40 milligrams Adderall unless there's some severe underlying cardiac issue.
Okay. But then, I'll just have to keep an eye on, have those conversations with her.
Exactly. Yeah. A lot of these patients, they've been cooking for years. So it's not like you're just going to come in and then, make one change and fix anything. It'll be a while before anything changes too.
Thank you.
Yeah, of course. Anything else on that patient?
No, that's all.
Okay. Then you said approach to FMLA paperwork, determining eligibility. Any legal considerations to watch out for? Do you require a certain amount of time? Patient needs to be established with provider before filling it out. Yeah, good question. Is there a certain scenario that came up, or like something that has you questioning?
Yeah. Well, so I work in a clinic. I don't fill out FMLA often, but I did have a patient. I have somebody on FMLA right now. And so navigating that, again, I don't have I don't have supervision. I'm kind of on my own. I'm the only person in my clinic who does psych. So these types of situations with like this, I have no idea. I talked to a few of my friends, to just get some baseline, but I was just curious, like, are there things I need to be, concerned about, or how, just so in the future, if I have people who come and see me on the first appointment, they want me to fill out this FMLA, how do you approach that? Or, are there legal things I need to be aware of as far as like how long you let someone stay on FMLA? I guess I just don't have a lot of knowledge in that area, so I don't have to do it a lot. So I was just curious.
Got you. So I'll walk you through some of my experiences, what they've been with FMLA. So when I did my work in the third year residency clinic, most of the patients that we had filled out FMLA type of stuff for was established patients. Like, they'd been there for at least a couple visits. And the reason we had that was because then what could happen is the patient would just come in for one visit, they get the FMLA, then they move on, and then you never see them again. And then, one, from a patient retention revenue standpoint, right, the clinic wouldn't support that. But second is that it's hard to really say that you can say this person should have disability or time off if they haven't had some kind of relationship with you, right? Like, if you just do evaluation, it's hard to say, especially for a psychiatric condition. If they have just broken their leg, like, yeah, whatever, like, that's obvious. But I'm assuming they're seeing you for a psych condition, anxiety, depression, or whatever. So that's a consideration. So at least for me, I try to do at least 2 to 3 visits. I haven't had a patient, if a patient comes in wanting the FMLA, immediately I usually say, hey, go to your primary or someone that you've been seeing. But if it's a patient I've been seeing for a while, for example, I had this autistic patient who we applied for Social Security for, and I'd been seeing him for a year, so I knew him well, I knew his faults well, so I felt confident writing about his faults. Whereas if the same patient had come in for the first visit, it would be hard for me to say that this guy qualifies for disability, just because I'd only seen him for one visit. There's no like hard and fast. It all depends on your threshold as a provider. I mean, I tend to just be more liberal. Like, after 2 or 3, I would feel comfortable, writing an FMLA if felt like I got to know the patient. But you're the independent provider in your practice, so you can really make that threshold where you feel like you understand the patient enough to confidently say that they meet criteria for FMLA.
Uh-huh.
I'll share.
That makes sense.
Yeah, I'll share another story with you where you might have to be careful. Is that sometimes patients can get stuck on it for so long. So I remember in my third year of residency, I inherited this patient, and she had been on, she had gotten some kind of FMLA for depression, and she had some incident maybe 4 years ago that had happened, and she'd been passed down from resident to resident. And so I inherited her, and I was going through her paperwork, and I realized that, so she always showed up for the FMLA renewal appointments, but a lot of the other ones, she would either not show up, or she would not renew her medication, or she would say that the medication wasn't working and make like changes here and there, but then she would never comply with the blood work. She wouldn't comply with medications, like changes that would happen. So it's this constant cycle that I kept seeing, and then I started talking to her, and that's when I realized that she's just kind of like prolonging and playing the game over and over again. Like she doesn't want to get better, because if she got better, then she'd have to go to work again.
Mm-hmm.
So like I would be doing her a disservice almost by continuing on the FMLA, because she just got locked into that pattern rather than encouraging her and helping her get better.
Mm-hmm. So what did you do?
So with her, I didn't renew it. I said, yeah. I said I don't think I can do this, because I was new providers taking over for her, the past one, but also I had this whole pattern. I was like, I don't think that I'm going to be able to treat you and get you better, because like there's no incentive on your end to do it.
Mm-hmm. Yeah, so then that makes a lot of sense. I mean, are there really any major like legal or, things to watch out for with it? I mean, basically, like if you can justify why you think a patient should be on FMLA, are you typically good? And then when they come to see you for the renewals, just making sure you're, documenting, like, is there really anything, other than that?
Yeah, not that I can think of. If you feel justified that they meet criteria for it, and you can use AI for this too. Like you can just type in whatever, like, hey, do they meet criteria for this FMLA, or based on just whatever the form says. You're not really going to get much backlash or anything. It's not like they're going to summon you in court and be like, oh, like you're lying or whatever. I mean, as long as you're not blatantly making stuff up, as long as you could provide some documentation, then you'll be fine. We have to remember that all of these people who read it, like the reviewers and stuff, they're not medical people. They're just the average lay kind of person. So with your credentials and with your assessment, like if they say, oh, a provider says that they meet criteria, okay, whatever.
Do you have do you approach that the same with like emotional support letters? What do you do for that?
I'm very liberal with that stuff. Like I am, yeah. I'll write those without any consideration. Like I've written apartment letters, like like one, I had a patient who wanted a dog for their apartment, but so I said, yeah, like this is an emotional support dog, because otherwise the apartment wouldn't let them have it, or they'd charge a fee.
Yeah, because I saw stuff more recently where people are a little bit more hesitant to write them, but I guess I've never had any issues with it, but I didn't know what your approach. I just wanted to hear what your approach was with that. But yeah, no, that all makes sense. So thank you.
Yeah, my view is always that if I can do whatever to help the patient, that's what I'm gonna do. So yeah, I'm less worried about legal things and stuff, but I'm more comfortable with it. But like other people may have different thresholds.
Yeah.
Awesome.
Thank you.
Yeah, of course. Anyone else have anything on that, or any other insights? Okay, so
I was going to ask, you mentioned the emotional support animal letter.
Yeah.
Do you have a template that you don't mind sharing? I literally had someone ask me for the first one today for an apartment.
Yeah. I'll dig through my. Let me write that one down. I'll dig through my notes and see what I wrote for a previous patient. I wrote a really detailed one time. So I'll dig through and I'll find that and I'll upload it.
Okay, thank you.
Yeah. Okay. Yeah, it was pretty much for an apartment. They needed an apartment, or they wanted the dog to be in the apartment. So I said, yeah, like, that's happy to help that.
So I wrote one time for 2 dogs, and then got a letter from a lawyer for the apartment company saying that they wanted me to justify why the patient needed 2 dogs instead of just one, and what 2 could do for them versus 1.
That's funny.
And now I am like super nervous to even write them because of that situation.
Yeah. So it was the 2 that got him. So they were okay with 1, but not the 2, right?
Yes.
Yeah. What did you say?
I put that the patient had both dogs for an extended period of time, and having to decide to give up one versus the other could cause even more emotional distress or something. I used AI and came up with like phone.
And did it work?
Yeah, they left me alone after that, but now I'm like super hesitant to write them.
Yeah, see, there you go. Remember, a lot of this stuff is just meant to scare you to not do anything. Think like that's why it's all just red tape. Think about insurance companies. Why do they have prior authorizations? It's literally because they want to stop. They don't want to pay for the med, so they just want to put additional barriers for us. So that way, we as the providers like, oh, it's too much work. We're not gonna go through it. Similarly with this dog thing, they're probably charging other tenants for the dog. It's more of a liability for the apartment to have a dog, so it's easier for them to say, hey, no dogs. So they would rather challenge you and see what you're gonna do about it. Like, you're not gonna get in any kind of legal trouble. You're not breaking the law by helping support this patient for their emotional support animal.
Yeah, that makes perfect sense.
Yeah. I always think about like what incentive do they have as an apartment complex. They just want to lower their liability. They want to keep their place clean, and yeah, and or charge you for it. All right, so Aaron, and you got anything else on that? Okay, so Aaron says patient is a 34-year-old male, aggressive physical and verbal outbursts, intellectual disability, autism, seizures, OCD, mood disorder. They're on risperidone, 4 milligrams, Depakote 1750, VPA level 80, Klonopin 0.5, Luvox 100. Excuse me. So quite a regimen. Better since adding Klonopin, increasing Depakote months back, but still cleaning, obsessively fixated, has labile mood, sleeping okay, but fascinated with horror films. At times, spasms seem seasonal, worse in the spring. As therapist, when Luvox is increased or risperidone is increased, patient has facial twitches. Thinking when increasing Luvox is raising levels of risperidone. Yes, yeah, they can have that interaction. Risperidone is increased 2 milligrams to 4 milligrams, not much difference. Few months back, switching to sertraline, so there's not drug interactions, but wanted mood more stable at first, or another antipsychotic. Lamictal failed, rash failed, Seroquel up to 500 milligrams. History of severe syncope episodes with low HR, BP, so didn't think Clondine was a great idea. Thoughts? Okay, yeah. What is your thoughts? I mean, this is a complex patient, first of all. Like, there's a lot going on.
It's like all mine are.
Yeah, I get that
I
sense.
like
And they want you to see these every 20 minutes?
No. I have a, sometimes I might see like 9 or 10 patients a day because a lot of mine are complex.
Okay.
So the biggest problem with him is he's autism, intellectually disabled. So I think it's really hard to tell whether there's actually a mood disorder or like a bipolar on top of all the other stuff he's got going on. And he's on the Depakote for seizures, so that's kind of like, I did increase that, which did help a couple months back because I had some room. And then he went to the hospital at one point, and they upped the risperidone. And I didn't see much change. I did the Klonopin, and he's done well on that.
Uh-huh.
Seemed like he did pretty good with the Luvox, but I get a little nervous when mom says he's like it's like she said obsessively cleaning and up constantly and doing all this stuff. So he's OCD, but he seems to have these high levels of energy. And he's attention seeking. So I can't tell when he talks about his horror films whether it's attention seeking or he's kind of manicky. It's very hard to tell.
Yeah.
So I mean, he's been very aggressive in the past. So my thoughts were to maybe try to switch the antipsychotic. It just worries me to up the SSRI if I'm not really sure exactly what's going on. So I've thought about Zyprexa. I don't love Zyprexa, but he's had a history of being physically violent with his family. So he does make me nervous.
Yeah.
I've also thought about, I don't know about any other antipsychotics like the newer ones to try, but I just don't know because of insurance.
Right. So let's walk through all those things one by one. So right now, right? So complex case. There's so many issues here that we got to prioritize. There's the OCD, there's the aggression that's happening, there's the Luvox interaction. What is the one thing that you want to prioritize or the family wants to prioritize with this patient?
Well, I think I've gotten it to the point where he's not physically aggressive right this second, and
Okay.
he's ramping up a little. So I think that's not the priority. I just don't want that to go downhill because I've gotten it. It's been better now.
Right.
But I think it's the OCD.
Okay.
With a patient like this, it's like impossible to do accurate screening. So I just don't know whether the mood, I really want to target the OCD, but
Okay.
I just don't want to play with the antidepressants because it makes me nervous when he's kind of labile and he's agitated
Yeah.
because I don't want to make it worse. And if risperidone is not doing it, I sort of feel like if he went from 2 to 4, he's not going to be any different from 4 to 5,
Mm-hmm. Got you. So right now you said that when Luvox is increased or risperidone's increased, the patient has facial twitches.
Yes.
And so when this risperidone was increased from 2 to 4 milligrams, were there facial twitches?
No. The Luvox, mom tried twice to increase it, and I thought, well, maybe it's a fluke. So we tried again. And I wasn't loving Luvox when he went to the hospital. They called me, and I was like, I really prefer you to use Zoloft first because I was like, he's got
Right.
seizures, and there's interactions.
Right. Yeah, because you mentioned switch to sertraline, so I was going to ask, is there anything holding you back from switching right now? Also, I'm going to turn on my lights.
I was just curious if I started ramping the sertraline up, if that would agitate him as far as if has any manic, would I possibly make him a lot worse? And then my thoughts are if the risperidone's not doing a whole lot, maybe he needs a different antipsychotic. Right?
Yeah. So let's walk through all of those things. So the first
I'm
thing
sorry,
you said,
yeah.
no, it's okay. So you said the manic thing.
Yeah.
We don't have any proof that he's manic because the labile mood could be his intellectual disability, autism.
Yeah.
Right. I suspect those are the primary things that are causing his mood lability rather than a bipolar spectrum disorder.
Yeah, he said things that are like hypersexual and stuff, but I think some of them might be attention seeking.
Attention seeking, lack of social skills.
Yes.
Lack of frontal lobe function from his intellectual disability. I suspect it's related to that rather than a bipolar manic type of thing where that tends to be more of a like a loss of control of a certain moment. Like a manic person wouldn't say hypersexual stuff outside of that manic or hypomanic state. Whereas
right. And that's, I
Yeah.
think maybe I need to trust my instincts instead of, sometimes I question myself when my instincts seem to be right.
Well, these are complex patients too. They make
Yeah.
it very easy to question your instincts, especially if the mom or the parent is like, hey, I think it's this, hey, I think it's that, and then the patient's saying, I think it's this, and then you have to put together all this data from everywhere and be like, no, like, I think it's this.
And he had a psychiatrist who retired, and the psychiatrist said, "Call me if you have any ideas and you fix anything because I don't know what else to do."
Right. So, so it sounds like you're switching to sertraline. So that sounds like a good move, because if the Luvox is causing interactions with the risperidone and you've already tried titrating it twice, you're not on a highly therapeutic dose for the OCD anyway. So switching
Right,
to sertraline
right.
does seem like a good option. So that makes sense. So you could do that. Risperidone, you could also consider Abilify in the future. It seems like that hasn't been used.
Sorry, he did use that.
Oh, he did. Okay.
I gotta tell you, I thought it was helping a little, but then when he went to the hospital, they're like, I think it was activating him, and I'm like,
Oh, I see.
I don't know. He goes through periods where he's activated. I'm not sure. So, but it did go up to 15. So, we tried that. He was better for some time.
Yeah.
I don't know, but that was before he was on Klonopin. I just don't, I don't. So yes, we tried Abilify. That's why I was like, I don't know what other one to use, but I just hate to see him on. That's a pretty, hefty dose of risperidone if it's not doing a whole lot.
Right, and the risperidone's mainly for aggression that you're trying to target, right?
Yeah, because he's he one of his parents had a hospitalization, I think, because of him. So
I see. So it's pretty severe.
yeah.
So it's important to actually get that under control. I mean, guanfacine or clonidine could be added as well. Those could be consideration. They won't be as strong as risperidone, but just could be considerations. You could also consider titrating up the Klonopin as well too. I'm guessing he's a larger individual, if I had to guess.
Yes, he is.
Yeah.
Well, and that's why I was a little hesitant with Zyprexa. I just know because of how volatile he is. Yes, he's a bigger guy. He's not super heavy, but he's not small.
Right. So like you could titrate this up further. Supplement wise, you could add N-acetylcysteine, NAC. That's my favorite for OCD. Could add magnesium and L-theanine to help with calming him. So this could be additional calming augmentation options that you can add. I would check out his gut health as well. A lot of the people with autism, like I always remember this case. This guy lived in a residential, and he would have these really aggressive episodes, and they would take him to the hospital. And the dad was an orthopedic surgeon, so he'd always get the fast track into the wards. And lo and behold, it was always that he was constipated, but he was nonverbal, and so he would act out that he would be very aggressive, and so they would pretty much just flush him out, and he would get better, and he'd stop being aggressive. So making sure his gut health is good, making sure his constipation is good, like he's not constipated. Those could.
Yeah, he's pretty verbal. I mean, he does talk to mom, so he functions pretty well as far as communication, as far as just talking in general.
Right. Even aside from the communication, check on his gut health. Make sure he's not constipated. He's stooling regularly. It's good quality, like not too soft, not too hard. It's not difficult to pump out, because that could tell me that there's maybe some gut health issues that are happening. There's evidence showing that treating for autism and intellectual disability, treating their gut health can also help their
Makes sense.
And then what about this Lamictal failed? Like, was it like the Steven Johnson rash or just a mild rash?
I don't know exactly, but I had asked the neurologist, and he said he would prefer me not to use it. So
I see. Okay, gotcha. Yeah, because it's an anti-epileptic too, so it might be conflicting with Depakote. And then I see the syncope here, low HRBP, dentin clonidine was a good idea. That makes sense. Yeah. So sounds like your thought is to sertraline. Fascinated with horror films. That just seems like an autistic thing.
It could be. Yeah.
Like it's not something.
Sorry, go ahead.
Yeah, not something that I would like consider pathologic by any means.
What are your thoughts as far as what antipsychotic would you consider if I try to do the sertraline and I decide to switch the risperidone?
Yeah, so Abilify. I mean, I mentioned Abilify would be one thought. I mean, that's the one that has the most FDA evidence. I know they said they thought it would activate him, but but that was before Klonopin. So that could be it. I know people in this group have mentioned Cobenfy as well, working well.
What is it?
Cobenfy, one of the newer ones.
Oh, okay, yeah.
Yeah, I've never personally used it for agitation, but I know other people here have. So that could be a consideration. I mean, I know Seroquel I also like because it's sedating and calming. I don't think it would be as helpful with
It didn't work for him.
It
Like, he went
didn't
up to like 500. The other psychiatrist put him on that, and it just did not work when I had him. He was way worse.
Oh, I see.
Yeah,
You said
okay.
failed Seroquel up to 500. Yeah. So, okay.
The only thing I knew is that, when Mom was really struggling before I put him on the Klonopin, I did give him 5 milligrams of olanzapine PRN a couple times, and he did really well.
And he did
And I was
well,
like,
yeah.
ugh. But
Yeah.
I know long term it's not a great benefit, but what are your thoughts on that?
Yeah. So, I mean, olanzapine is good. It's solid. It definitely hits the dopamine receptor pretty hard. So, I think it's a good option for sure. Clozapine could also be considered if the family is very, like, they're able to get him the labs and stuff.
Okay.
If you're worried about, or Geodon is also a good option, as well too. It's got low metabolic burden, so that's nice.
Okay.
So that's the nice thing about Geodon. Just has to be taken twice a day, but with him that could be beneficial because then you spread it out.
Yeah. What do you think of the fact that his A1C is it's like 5.5 with olanzapine? But if I was putting him on that, maybe I could get him to a lower dose than the risperidone. Maybe he wouldn't have to take as much.
Yeah, 5.5 isn't bad. So it doesn't sound it doesn't sound like he's not even pre-diabetic.
No. And he exercises all the time. So that I was happy with when I heard Mom say that.
Nice. That's really good too. Yeah.
All right, thanks. He's complicated.
He is, yeah, and just remember that with a lot of these, like, you can only do so much to manage him. Like, a lot of it's just, like, it's on his own condition. It's like if a patient comes in with terminal cancer, like, the oncologist shouldn't blame themselves if they can't miraculously cure the patient.
Yeah, and I think Mom just keeps telling me she's just trying to keep him safe, and keep everyone safe,
Exactly. Yeah, anything else on him?
Thank you.
Okay. And then the next question you had, can we review best psych meds to use in cardiac patients? Yeah. Was this just in general, like a specific patient you're thinking of?
Well, I have a patient that's severely depressed, and he's on a bunch of stuff for epilepsy. He's on Lamictal. He's on, I'm trying to think of what else he's on offhand, but he's tried sertraline. We've gone up to 200. He's OCD with very, very, very low mood. But he had an MI 10 years ago. He's got, he had like a weird EKG like 5 years back.
Yeah.
I just, I was thinking about switching the antidepressant, but I just didn't know. Maybe mirtazapine. I don't know. He's really skinny. I don't know.
Yeah. So, okay, so let's walk through all of this. Basically, with cardiac concerns, we're trying to optimize for a couple things. So the number one is the QT prolongation. So some of our meds cause QT prolongation. We just want to make sure that we're doing stuff that's low risk.
Right.
Blood pressure, like either hypotension or hypertension. Some of them cause tachycardia. So those are really the main things. QT, blood pressure, either increase or decrease, and tachycardia. So then going through the categories, if we have SSRIs, the SSRIs, generally sertraline's pretty safe. Lexapro tends to be pretty safe. Citalopram has the highest QTC prolongation risks in the SSRIs. TCAs, those are less safe. They have QTC lung prolongation risk, and they're dangerous in cardiac overdose. They can cause arrhythmias. So that one I would be hesitant about. We get to antipsychotics, right? Geodon, ziprasidone, that's the worst one for cardiac. Some of the lesser potent ones like Seroquel is less so. That one's on lesser end. Abilify's on the lesser end.
That's what I was gonna say. I could think about augmenting with like a little Abilify or something.
Yeah, a little Abilify, lorazepam, olanzapine. Those are the QTC prolongation ones that I would be better okay. Sorry, yeah, olanzapine, Abilify, Latuda. Pretty much Geodon would be the one that I would be really hesitant on, and Haldol.
Yeah.
Those would be the top two I'd be thinking about.
Okay.
Yeah. Then obviously propranolol if there's like a blood pressure thing, or clonidine and guanfacine, right? You can just, if they have too low blood pressure already, if they already have high blood pressure, I'd be cognizant of Effexor, not wanting to jack up their blood pressure too much.
He has a history too, so that's why I was thinking too. I get Remeron. I mean, isn't that fairly safe in cardiac patients?
Remeron's pretty good. Yeah, Remeron's pretty good.
Because he's a thin guy. That's why I was asking. He's depressed, really thin.
So Remeron and Zyprexa could be helpful, like for treatment resistant.
Yeah, I get nervous to change the Zoloft because he's been on it for so many years.
Yeah.
And he's so obsessive. So I'm like, if I start taking that down,
right,
that might even get worse.
Zoloft's a good choice too. Lithium, so that would be, I would be careful of because there is cardiotoxicity that can happen with lithium. So that one I'd be hesitant on. But yeah, other than that, our meds tend to be pretty well tolerated cardiac wise. Oh, and then stimulants too. Just be careful if there's arrhythmias or any kind of like structural heart problems.
Okay. Yeah. Okay. That's helpful. I just wanted to kind of make sure I wasn't missing anything.
Yeah, of course. Yeah. Anything else, or anyone else have anything on that topic? Okay. Perfect. Any other questions that we have, or anything we didn't cover?
I have a patient similar to the one, is it Aaron that you shared?
Mm-hmm.
Oh, I feel like I have his twin. I have a 21-year-old male who just presented to me 2 days after being discharged from inpatient, severe IDD, chromosomal abnormality, autism. And I think I brought this up yesterday. He had a previous diagnosis of bipolar. I talked to his mom kind of at length today, just trying to dig out some more history. And it sounds like he just has a baseline of aggression and irritability. And so I inherited him on Depakote and history of seizures. So he's on Depakote ER, 500 milligrams TID. Geodon 60 milligrams BID, and clonidine 0.1 TID. And so he's still aggressive. He's just like, he has pretty significant daytime somnolence. And so the mom's actually getting to the point where she's concerned about whether or not she can continue to take care of him at home by herself. He's 6 feet, 221 pounds. And right now he's calm when he's sleeping during the daytime. He wakes up aggressive, but still, because of the somnolence, just not as dangerous. And so I was actually thinking about getting rid of the Geodon and going towards Zyprexa. But you just mentioned that it was a pretty good option. He's large, but he's got pretty good muscle mass. He's not a lot of fat. So I felt like he could tolerate, as long as we watched him pretty closely, the metabolic effects of Zyprexa, but maybe just maxing his Geodon might be beneficial. He's done Invega and had a pretty significant adverse reaction. They had to hospitalize him. Same thing with Abilify. The mom said that risperidone was effective as a child, but as he got older, it became less effective. And Seroquel also was helpful for a little while and no longer effective.
Yeah, I see. Got you. So, basically, this right. So, 21-year-old, he's got the IDD. So you're saying that he's either sleeping during the day, but he's aggressive when he's not sleeping.
Correct. Correct.
So the problem is mainly, is he just having poor sleep?
She said he's sleeping during the night. Just this new regimen, he's much more somnolent.
I see. Okay. So basically, when he wakes up, so maybe he's getting too much sleep. That could be a problem too. Is he sleeping well during the night, or is it more like restless kind of sleep?
It could be restless. She said that he doesn't appear to be up and down.
Yeah.
But it could be.
It could be, yeah. Okay. Because just like we know that too little sleep can cause aggression, too much sleep can cause it too. So that's what I'm wondering. Like, if that's the case, it's almost, think of it like if you sleep too much, you have to burn a certain amount of energy throughout the day.
Right.
And to be able to facilitate that drive to sleep again. And so this guy might just have so much energy that's getting misplaced into aggression.
Yeah.
Okay.
Just one thing to think about. Risperidone's good as a child. Maybe it's just because his metabolism was changing from going from child to adult. So it could be worth trying again. I mean, that's got most evidence behind it. Is he compliant with his meds?
He is. And he's actually really good at getting labs. I have him going to the lab in the morning just to see where we are with Depakote.
Oh, okay. Got you. Okay. What about the Geodon? Does he take it with food?
I'm not positive that he's taking it with a meal with both times.
Okay. Yeah, because it should be taken with 500 calories.
Yep.
So he might be having less absorption, therefore less therapeutic level than he needs.
Okay. Look.
So just something to consider there. Do we know why he's somnolent throughout the day? Is it because of the clonidine?
I think it could be the clonidine.
Yeah.
3 times a day.
Yeah. So what if we either switch to a long-acting clonidine or something less sedating than guanfacine?
I actually like guanfacine.
Yeah.
I love guanfacine.
Yeah, to help to lessen sedation. Yeah, just so maybe he has more energy and more up able to do things during the day. And like, why is he being aggressive too? That's my other question.
So the mom said they've had a hard time. It got worse about age 14 and he was just larger and he's just irritable, aggressive. He's even becoming a little bit more aggressive recently with neighbors and antagonistic, she said, even. Which is how he ended up hospitalized most recently. The neighbors called the police on him.
I see. Okay. So that's definitely a serious concern, but we're not sure why, he just is.
Yes.
Like, there's no triggers that are identifying things going on in life.
So the mother also takes care of a nephew who is autistic and has IDD, who is a few years older than he is. There's another brother who's neurotypical, lives in the house. He definitely is a trigger for the brother. She said just seeing him, he's instantly irritable. Also, his hospital records show that he was positive for amphetamines. the mother in their report stated that he was on Adderall. She didn't report Adderall to me, and I don't see where it's been prescribed.
Oh,
So
that's
there's something also.
yeah, that's suspicious.
Mm-hmm.
Right. I mean, that's a clear irritability
Yes.
thing. Like, what if he's how is he well functioning or not well functioning?
Not well functioning.
Okay, like maybe is it possible you could have obtained something illegally or is using something illegally?
It's possible. I consider that because he is allowed to go outside and kind of roam the neighborhood without supervision.
Yeah.
And so,
I'm sorry, I was just interjecting one thing. Could it be possible that somebody in his family, like one of his parents or something, gave him Adderall of someone else's, like someone else in the house, thinking, oh, it might help him. Let's see. I don't know.
I've had one meeting. It's definitely possible.
What's your gut telling you?
So initially, I think the mom's just tired, and I think she is not. There's not as much oversight now as there has been, and something's going on with the neighbors. They are pulling away, not interacting as much with him. The mom said there was something going on with that. She just mentioned today, which she didn't in our initial meeting, the dynamic with the older brother. So I don't know.
So your gut's saying that it's mostly this psychosocial stuff that's going on. Older brother, neighbors
Yes.
pulling away from him.
Mm-hmm.
Yeah. And he's probably very sensitive to that. He probably doesn't have that many friends or connections, and now these people are all trying to pull away from him. Mom's pulling away, older brother's causing grief, neighbors are pulling away, and this is how he's reacting.
Bonding. Yeah.
Yeah, or like trying to respond as best he can.
Mm-hmm.
Does that seem accurate, or like
It does. It does.
Yeah. Is there any consideration for a residential for him as you reach that level?
I didn't get that. Could you try again?
No, yeah, sorry.
I thought so.
Yes. The mom
Sorry,
tried to
Mike.
get assistance and wasn't successful in that discussion with the case manager when he was inpatient. And I don't have any resources.
I see. Okay. So, could you repeat that? Sorry, that my Siri had kicked in and it cut off the first half.
So yes, in our initial evaluation, the mom mentioned just being open to residential facility for him. But she said in the inpatient setting, case manager, they weren't helpful in identifying a facility for him. And I don't have any resources, but she's definitely, she's ready.
Okay. So there's no case manager, there's no social worker, nothing.
No.
And your workplace isn't able to help them find it or offer it?
I got no response.
Okay. Then it sounds like mom she probably has to do a lot of the heavy lifting
Mm-hmm.
On her purchase. That would probably be the number one thing then, if she wants to pursue the residential. Either finding the residential, even searching for it online, calling up different places. What state are they in?
With Texas.
So in New York, we have this thing called OPWDD, which I'm not sure if they have it in Texas. Let me share my screen.
Okay.
So when I used to do some emergency room work, we would have these aggressive cases come in New York, and they would refer them for OPWDD. So basically, it's like a governmental office, and it helped find people direct resources for that.
Okay.
So I'm wondering if Texas has an equivalent of this OPWDD. It helps families find resources specifically for people with autism, developmental disabilities, etc.
Okay.
So I'm just wondering if there's a Texas version. Okay, developmental disabilities. Okay, so it looks like there's some stuff here. Local intellectual disability, Texas Health Human Services Commissions.
Yes, I see that.
Yeah. So maybe mom has to start searching for a lot of this stuff now.
Okay.
Yeah. This is one of the toughest areas for sure. Like, there's so few resources for this population. It's a very it's a tough thing for sure.
And my inpatient, so when I worked in the inpatient setting, patients like this one end up in state facilities.
Right.
The rest of the facilities stop taking them or try to decline them when they hear anything about aggressive behavior.
Right.
And they end up in state facilities.
Right, exactly. We had the same thing as well too. Yeah, I've seen that. Oh, but then the other thing I was going to say is maybe an SSRI can be helpful. So I have this 25-year-old gentleman. He's similar. I think he's a little bit more well-functioning or higher functioning. But for him, I specifically remember he was on Prozac, I think 60. He was doing well. So I was like, okay, let's try to taper it down. Tapered it down to 40. And then next follow-up, they were like, no, he's way more anxious. He's acting up. He's getting very aggressive. Brought him back up to 60, and the aggression he was having went away. So the aggression could be related to anxiety, especially because now we see that where he's probably anxious with the mom pulling away, older brother issues, and now neighbor pulling away.
Right. And he's never been on an SSRI. I don't see it in his previous method.
Yeah. So that's a low-hanging fruit that you can definitely pursue as well.
Okay.
I have a question on that note. I keep running across these patients, and it's not just the autism population that I inherit, where they have a bipolar diagnosis, like it sounds like your gentleman just did. And it seems like every time they go to a psych provider, nobody wants to try an antidepressant or an SSRI because of that bipolar past diagnosis. What are your thoughts? Just curious. Because I even have some patients that have had bipolar diagnosis that I can't find evidence of anything.
Yeah.
And they, like past providers, just refused to try an SSRI. What are your thoughts on that?
Yeah, I think it's a fake diagnosis in a lot of cases. Oftentimes, I remember I used to work in the inpatient unit. They wouldn't cover for any kind of autism things. So you had to put down bipolar to get coverage.
Okay.
That's what I was told, at least. And so I suspect that it's probably related to that. Plus, I think that diagnostic standards back then were less, so rigorous, or bipolars are very misdiagnosed, or the provider may not have been that experienced. Bipolar misdiagnosis is common across our field, so it happens to patients in all spectrums.
Okay, because I see so many patients where they're just like, I'm irritable. That's why they gave me a bipolar diagnosis. And I'm like, okay, what else? And I go through all of them, and they're like, I'm irritable.
Right. Yeah, obviously you have to take the patient's word with some grain of salt, because not everyone is that cued into their thing, to their own health history. But yeah, a lot of people definitely get misdiagnosed.
So do you take a chance sometimes with those patients with an SSRI? I guess that's my question in this case as well, too.
Yeah, I do, because right now we know that the patient's clearly struggling as it is. Clearly that what we're doing is not working. So with every med we start, we have to evaluate the benefits versus the risks. And so there's already so much dysfunction and problem happening already that the benefit of starting an SSRI may outweigh the risk of potentially causing a bipolar manic episode.
Okay. What if the patient's never tried an SSRI, has only been on mood stuff, and still has severe depression, and you think there's a misdiagnosis? Would you still start an SSRI?
Yeah, I think that would push me to even more do it, because especially if they haven't done it, I'd be like, well, we have such a good opportunity here to make a difference for this patient, especially because they haven't tried anything.
Okay. So if they turn manic, then that's just a chance you take, I guess.
Of course, that's the chance you take, right? But just like we were saying yesterday, just because there's a chance that a bad outcome might happen, there's a chance that a good outcome might happen too, and sometimes you have to risk it to get the reward,
Okay.
right? Otherwise, no one would ever start a business. You wouldn't even go driving if you're afraid that you're gonna get hurt all the time, right? Like chemotherapy is a risky thing. It may not work. It could cause severe side effects, but plenty of people do it because the potential reward outweighs the risk.
Yeah. Because I've heard some providers say, I just go right to a mood stabilizer because I don't want to even take a chance if I don't know.
Of course, and you can certainly do that too. So, for
Right.
example, in this case, the person looks like they're already on Depakote, which
Right,
is a mood
right.
stabilizer, and they're not on SSRI. So it depends on the patient. Let's say hey, you haven't tried a mood stabilizer, and then yeah, certainly you could try a mood stabilizer. But for example, when I think of this case, they've tried mood stabilizers and antipsychotics, and there's no SSRI that's ever been done.
Right,
So then that would lead me towards that.
Yeah.
Yeah.
It's just hard when you don't think a patient's bipolar to go right to a mood stabilizer is such a heavy drug, I feel like, compared to an SSRI.
Yeah, but that's why they come to us, right?
Yeah.
Like we are the expertise here, so
Right.
they're coming to us for our experience and our expertise and our judgment, our clinical judgment, and that's why like AI can never fully replace us, because AI might say, yeah, mood stabilizer would be bad, but it may miss some of the nuance that we would know from experience.
Okay. Yeah. All right.
Yeah, does that make sense?
Thank you. Yeah, it's just, you just can never be 100% sure. I think you're right. And you just got to go with your gut, I guess.
Yeah, and that's it's all what it's about. That's why we get experience. It helps us develop confidence. Yeah. Anything else? Anything else we didn't cover, or any other cases?
I just have a really, oh, sorry, I don't know if somebody else is going.
No, you go right ahead.
I just have a really just general question. What is your approach to patients being on benzodiazepines and stimulants at the same time? Is that something that, like how strict are you with that? And like, let's say if they're using both daily.
Yeah, good question. So I remember when I was in my residency, I had this young attending I worked with, and so he was like, if a patient came in, they wanted either a benzo or a stimulant, or like I was thinking of putting them on both, I'd be like, okay, pick one, and that's what we're gonna do. That was his. I've had other attendings who are absolutely like, no controlled substance if you've ever done something, ever, like if you're on a substance or anything. They were very strict with it. I personally am more liberal because I see both things. Like people can have ADHD and anxiety. People could really need the two, and they're not mutually exclusive either. Like patient could really benefit from the stimulant effect of a stimulant, but then they might have some irritability and things, or it might worsen anxiety a bit, in which case you could use a benzo. It's certainly not ideal. Like it's never something I would go for first line, but I do feel comfortable managing it if the situation requires it.
Okay, yeah, that makes sense. I think I just, I never know how strict to be with people, or especially when it's, like if they're on a stimulant daily, but they use, Ativan once in a while, okay, that's one thing. But,
right.
The people that are using both every day, that's where I just sometimes have trouble, like deciding if, okay, do we need to make a change here or what? So I was just curious what your general approach was.
Yeah, I mean, like typically I don't want patients to be on both. That's where you could also prioritize too. Think about like, what is your long-term goal with this patient? Are you trying to just keep them stable where they are at? Are you trying to help out de-prescribe them? What is the patient's goal? What's a higher priority with the stimulants treating or with the benzos treating? Those would be the questions I'd be asking myself. Knowing probably the biggest is what's the long-term goal with our current regimen?
That makes sense. Thank you.
Yeah. Was there a specific case you were thinking of, or just like in general?
No, I guess not enough. I actually don't really have anybody right now that's on both, but just, in the past seeing people or inheriting people, who even in their past were on both every single day. And, I've had a couple here and there. I can't think of anything off the top of my head, but I just was curious because I'm sure most of us run into that dilemma sometimes. And so.
It's definitely not ideal. Don't get me wrong. It's not like A-level practice, but some patients are complex. Sometimes patients get on that, they get stable, and then you're like, okay, I'm not touching this with a 10. If they're stable, I'm just maintaining it or making slight tweaks here and there.
Thank you.
Yeah. Anything else that people had?
Hi, good evening. I know I'm joining in a little late. I have a follow-up question, Madison. What kind of setting do you practice in?
I am in a private practice, and we only take commercial insurance.
Okay. I noticed that the setting sort of sets the norm, the trend. More academic settings will prefer to be more conservative with this kind of treatment. So a private practice is also keeping the patient happy. Also, obviously, keeping in mind that we want them to thrive, that we want them to make progress, but keeping them happy is a very important component.
Facts.
So sorry, go ahead.
No, I said that's a fact.
So something that I find myself doing often when a patient was already in a benzo asks for a stimulant in private practice is that I like to sort of always inform them in things that are more technical and they don't necessarily need to know, such as the fact that it will raise